Just a second. Let's make sure we're good here.
I just got the notification.
You
Sorry.
did? Sweet.
Well, welcome back to the Dental Guys. This episode is here live once again from the American Academy of Fixed Prosthodontics and presented today by Quintessence. Thanks again to Quintessence for sponsoring us to be here today and get to talk to some pretty amazing people. And this is really an honor for us because we've talked, or we have read your books, Dr. Al-Faraje, and he is here with us today to speak about who he is, about his books, about some training that he's doing. So welcome. Thank you for being with us today.
Thank you for the invitation. It's an honor. Great meeting here at the American Academy of Fixed Prosthodontics, and it's my pleasure to talk to you.
Yeah, we've what we were just talking about when we had kind of been introduced and we saw, oh gosh, this is the guy that wrote the book on the checklist.
Right.
And checklists are so important to all of us. And in fact, it seems like each person we've talked to, anybody that has developed any type of training, has realized that the checklist is critical, especially when you're beginning, but even maybe more so as you get experienced and you get to the point of being in a more complex treatment. You talk a little bit about, just kind of tell us about yourself. For those of you who are not familiar, tell us about who you are, what you're doing, what books. You tell us about your books a little bit. Kind of what does your day look like day to day in your practice?
Well, I practice in San Diego since 1994. In 1996, I started doing implants, the surgical and the prosthetic portions of implant dentistry. Did fall in love with the implants from first surgery, if you will, from first seminar. In 2002, I started the California Implant Institute. We provide didactic and surgical courses, live patient surgical courses in San Diego, in Mexico, and at UNLV Dental School in Las Vegas. I started the writing books in 2011, and the first book was Surgical Complications in Oral Implantology with Quintessence Publishing. And then we have the anatomy book and the checklist that you mentioned already, and the oral implantology review as a preparation, as a help for dentists who wants to be credentialed. Credentialed in this discipline with a variety of bodies, the ICOI, the AID, or the American Board of Oral Implantology.
Okay.
Wonderful.
So you're doing a lot of training in different locations, and one of the things we were talking about before the show is I'm always interested in the beginning of surgical training, because there are kind of two different camps as to how you first teach a new implant placer. Do you teach them to do freehand surgery first and then integrate guiding, or do you teach them to do guided surgery? Tell us a little bit about your philosophy on that and why you choose to do it the way you do.
Well, guided surgery is wonderful, is fantastic. You get the job done quick, and if the patient is a candidate for it. And as you know, more and more now, the digital way of doing and restoring implants is getting more and more popular. That said, I think when you start doing the surgical portion of implant dentistry, in my opinion, my philosophy at my institute is you start with the freehand. You need to be very proficient at placing implants in very close to ideal, if not completely ideal, placement, buccolingually, mesiodistally, angulation, depth-wise, without any help. For a variety of reasons, because many bone grafting procedures do require flapping and some bone modification before placement of the implants, and that makes it not possible to have guided many scenarios I can name, but also sometimes you might get a guide that is not properly fabricated. There might be an issue with it. Of course, you do not want to reschedule the surgery for 2 weeks later to get that guide, or even 2 days later. You would like, in that case, to take over and perform. I mean, think about it as flying an airplane and something happened to the autopilot. That's exactly what guided surgery is. It is autopilot, and things can go wrong with autopilot. You need to be proficient and being able to navigate and maneuver the airplanes and land safely without any help should that arise. And in case of implant dentistry, the scenarios are more will come more often than something getting wrong with the autopilot where you have to take over and do freehand. So you have to be proficient at that.
John, again, somebody that agrees with me, I like them already.
Yeah.
And
It makes it easy.
it does make it easy to have a conversation because you're kind of in my camp on this. Is I, grew up around implants. Started in 2003 placing dental implants, and went from doing poor man's stents to learning more and free-handed and doing some of the first guided cases. And in East Tennessee, I was glad to be a part of that group that was able to do that and incorporate all the cool technology that we have today with cone beam tomography and scans and high-quality impressions. But the idea that you're placing a three-dimensional object into a three-dimensional space, and you need to be bound by bone, and understanding that we're not just treating a table or a block here, or we're not just putting in something that can go anywhere as long as the tooth's in the right position. There are limits to anatomy.
Well, and soft tissue. I mean, we talk a lot about this, that, you're saying these things and, you mean you can't just tissue punch every case? I mean, this is the kind of thing that, like you say, understanding how to develop a flap. And many people are taught that guided, and they have no idea.
I think you should speak to that, is because there's so many budding clinicians that want to get into implant therapy today in the United States. And one of the things that it was taught years ago is like we can punch, right? And that just bypasses some critical things when it comes to incision design. Talk
a little bit about that.
You can definitely punch, but if you ask my opinion on what is the percentage of cases that are candidate for flapless placement, I would say 5%.
Love it.
Love it.
That's absolutely been my philosophy, and
hope
all my
people are
students
listening
know
to
that.
this.
Yes.
Because in order to do flapless, as you know, properly, you need plenty of bone. When you place implant, when you're done, we would like to have close to 2 millimeters on the buccal and lingual, if by all means possible. According to literature, 1.5 millimeter is the minimum for a good for the longevity of the implant. If you want like good longevity on it, you need to have 1.5 millimeters. And sometimes it's very critical. You can barely have that minimum. And to do blindless, if you will, flapless, there is nothing wrong with flapless when you have all the bone in the whole world. I mean, if you have a ridge that is 15 millimeter wide, and that's probably from time to time you will encounter that in the posterior maxilla, for example. Nothing wrong with that. But I would say, again, well below 10% is the implant sites that are candidate for flapless placement. So you have to learn how to open flap, envelope flap, 2-wall, 3-wall, full thickness. And almost we do nothing but full thickness, which is quite easier than partial thickness, a flap as you might need, in periodontology for soft tissue grafting. So for implant placement, for bone grafting, we do almost nothing but full thickness flap. It's not that hard. I don't think it's smart to try to avoid learning how to properly flap. And then, most doctors are rusty or don't have enough training on suturing. You need to take some classes and make sure you do a good job on suturing. I remember one student telling me, I don't have problems opening flaps. I'm scared because I'm not sure I can close them when I'm done. Many doctors do nothing but single interrupted, and that's probably not the right way to do in long flaps, or large flaps, or for the papillae, etc. So there is no way around that. If you're planning to get involved in the surgical phase of implant dentistry, you need to be very proficient at anatomy, so you don't cause any anatomical damage. You need to be very proficient and comfortable with flapping and with suturing when you're done. And this is the right thing to do.
Software and technology has created autopilots. I love it.
Yeah.
And they're great, but you've created an institute surrounding understanding more than just you understand the technology and utilize it in teaching. What's the trigger point when you go from, hey, this doc has got it, right? He's ready to go to the next level, which is guided surgery, or understand when guides are appropriate. How do you teach that?
So when the doctor is proficient at freehand teaching him how to do guided surgery would be a piece of cake at that point, because he perfectly understands how to place some with a free hand. And obviously the guided is easier. You just need to have some computer skills maybe, and to be able to do virtual treatment plan using whatever software you're using, and then transfer those files to the lab to fabricate, or to your own 3D printer to print the surgical guide. And so the training, the learning curve at that point would be much shorter. You start immediately with the guided, the learning curve of it is longer, and the freehand part of it is zero. So definitely the right way. I always say guided surgery is definitely not for beginners. You start with non-aesthetic zone, plenty of bone, number 19, number 30, number 3, number 5 maybe for certain patients, and you start with edentulous areas where you are 100% in control from the first drill. And you numb the patient, and you start with envelope flaps where you don't have to do any releasing incisions. And you x-ray as you proceed, just like an endodontist. You know, you have the Lindman drill to adjust your osteotomy, your angulation. And then you place the implant, and you do that like 10, 15 times. And now you start placing multiple implants, and then you go to the immediate placement after extraction without immediate loading, and then you go to the aesthetic zone, and then you go to immediate loading.
I love it.
So
It's
you
logical.
definite
It's
baby
logical.
steps. I mean, there is no way for success without doing baby steps.
Yes,
In
and
any discipline, in
absolutely.
flying or in surgery or in anything.
Yeah.
Baby steps. They can be fast baby steps, but they have
Yes.
to be baby steps. You start here. You know, you learn how to walk, and then you learn how to
Well,
run.
and you're teaching people how to think, and you know that is to me what is freehand surgery. It's you're being a doctor. You're thinking through this case. No one's doing the thinking for you, and I think that when you run into problems, as you said, if you have a guide that doesn't fit, you know, the feel even of tissue and the feel of bone, you lose all of that when you are operating within a guide, and so teaching. Starting off with, okay, we're going to teach you how to think through these cases so that, as you say, when the autopilot fails or when something doesn't go quite right, you're okay. You're okay. And that, I think, too, creates a confidence for a doctor going back to their practice that they say, you know, I'm okay, even if the worst